Assalamualaikum warahmatullahi wabarakatuh, students. This is Dr. Uzaimi of Department of Pharmacology. Welcome to my lecture on drugs used in acute coronary syndrome. I'd like to first start with just a quick run through of what happens when a patient presents with acute coronary syndrome. The first priority is usually to prevent further damage to the myocardium, as acute coronary syndromes happen in the background of myocardial ischemia. So these 4 steps is usually in the mind of all doctors. Firstly is to alleviate the pain and to calm the patient down. We want to prevent further thrombosis or enlargement of the current thrombus. In doing the first objective, we also reduce cardiac workload. And then finally, we try to remove the thrombus that is forming in the artery, in the coronary arteries. So for there are specific agents that we use. So the pathophysiology of acute coronary syndromes is related with myocardial ischemia. This is a normal heart with a normal caliber artery here. You've got the endothelial layer as well as the tunica intima, tunica media, and adventitia here. A patient who has the risk factors for developing atherosclerosis will have some sort of either hypertension or hypercholesterolemia or even type 2 diabetes. And their artery will show buildup of cholesterol plaque. This buildup occurs underneath the endothelial layer in the tunica intima. And this over time will result in arterial narrowing and impairment of blood flow. Over time, the size of the plaque will grow and the surface of the endothelial layer will become weaker and weaker until one day it will rupture, thus leading to thrombus formation on top of the narrowed segment of the artery. This is what happens in cases of myocardial infarction. Acute coronary syndromes are the syndromes that develop when some of these incidents happen. There are usually 3 types of acute coronary syndromes that we can see. The first one is unstable angina. Now, I'm sure you've already remembered what angina is. If you haven't, then please look back at the pathology lectures talking about atherosclerosis. So coming back to this lecture, unstable angina happens when there's worsening of stable angina or when the angina occurs at rest. However, this worsening or angina occurring at rest does not induce any ECG changes or any alteration of the cardiac enzymes that would indicate that myocardial ischemia is so bad that it leads to tissue damage. The second type is a bit more severe. This is called a non-ST elevation MI, and in this case, the worsening of stable angina or angina at rest occurs together with some sort of ECG changes, such as T-wave inversion or ST depression. Furthermore, there are also alteration of cardiac enzymes, which are elevation in SCKMB or troponin T. Now, this is a more acute or a more severe form of acute coronary syndrome, and there are evidence of myocardial ischemia leading to some sort of tissue damage. However, in this case, the objective of pharmacotherapy here is firstly to relieve the pain and secondly to prevent the recurrence of ischemia, as the ischemia that happens in non-STEMI is usually reversible. So agents that are used here are the opioid analgesia, which is morphine, any of the antiplatelet agent, or probably both of them, aspirin and clopidogrel. And if you remember from your previous lecture on anticoagulants, they are also used here to try and prevent recurrence of the ischemia. The agent of choice is usually any of the low molecular weight heparin. The final type of acute coronary syndromes would be your ST elevation MI. Now, this is what laymen would call heart attacks. And the angina that occurs here is either at rest or worsening of the stable angina, coupled with ST elevation on ECG, as well as alteration or increase in the cardiac enzymes, both of CKMB and of troponin T. In these kind of cases, aside from the normal management like we use for unstable angina and non-STEMI, the other objective is to restore oxygenation to the injured myocardium. So for this purpose, thrombolytics are used. So just to recap the drugs used in ACS, you'll have your morphine, your antiplatelet agents, nitrates, beta blockers, ACE inhibitors or ARBs, anticoagulants, and finally the thrombolytics. For the purpose of our lecture that I'll be covering, we are going to talk mostly on antiplatelets as well as the thrombolytics. Now, looking back at the narrowed blood vessel just now, I'd like to describe a little bit of what happens when an atherosclerotic plaque ruptures. This is a very simplified diagram of a cross-section of an artery with an atherosclerotic plaque. So as the atherosclerotic plaque grows in size, the pressure inside it as well increases, and where it reaches a certain point and it ruptures. Okay, when this happens, a cascade of events follows, which leads to the formation of thrombus. Firstly, there is platelet activation, okay, which leads to platelet adhesion as well as aggregation. This is coupled with activation of clotting factors to help cover the wound that is detected by the body when the atherosclerotic plaque ruptures, because this rupture occurs when there is separation of the endothelial layer that usually covers on top of the atherosclerotic plaque. So the process that happens after that, formation of thrombus and everything, is similar to what happens when you have a cut on your skin. The purpose is to prevent bleeding. Platelet adhesion and activation of clotting factors will form fibrin, and once this fibrin net is present at the area of the rupture, it will start to trap red blood cells in it, and it will start to grow bigger and bigger. Luckily, our own body has its own mechanism to counter this formation of intravascular thrombosis. There is plasminogen present in the blood vessels. When the rupture occurs, besides activating platelets and all the clotting factors, the endothelial cells will also release something called the plasminogen activator. Plasminogen activator will, as the name suggests, activates plasminogen into plasmin. Plasmin will then interact with the thrombus, specifically interact with the fibrin to dissolve or to cut the fibrin, making fibrin degradation products, and in doing so will release the trapped blood cells and reduce or halt the growth of the thrombus. Now, where does all the drugs that we can use act at? Firstly, we've got the antiplatelets like aspirin and clopidogrel, which prevent platelet activation, therefore preventing the first part of the cascade of events that leads to thrombus formation. The second group of drugs that we use are the anticoagulants like warfarin or low molecular weight heparin. This also act to prevent thrombus formation by reducing the activation of the clotting factors. Finally, there is another group of drugs that acts directly on the thrombus once it is already formed. They are called the fibrinolytics, and fibrinolytics acts much like the plasminogen activator, where it accelerates the transformation of plasminogen into plasmin, and thus will increase plasmin concentration in the blood vessel to interact with the thrombus and degrade the fibrin. This is the end of the first part of the lecture. Please review your pathology and your physiology if you couldn't follow the content of the lecture. And the second part will deal with the specific agents that we will be encountering. See you in the second video.